All right, welcome back, folks. Welcome to another RLR. In case the folks who were here live when I accidentally let everybody in thought that we were anything but 100% honest and authentic, we were gossiping about the person who left a comment on Prof. Rez's Prof. Rez's video that he ruined the episode with his sub-quality mic. We were talking about you, whoever you were. But anyway, today we have a really, really special all internal affair. And before I tell you about who's presenting a case, we got to tell you about who's anchoring this work today. And we're very, very grateful to now, I think, our like regular RLR scribe, Zakaria. I'll hand the mic to you, my friend. Tell us where you are, what you're up to.
Hi everyone. Yeah, so I'm Zakaria. Yeah, I usually scribe on Fridays when I have a chance, as it usually fits in with the South African time where I am. Finished orthopedics today. Going to be moving to a clinic and starting family medicine, and yeah, quite looking forward to having some more independence and being away from all my seniors and specialists, and starting to make my own decisions. Yeah.
That's a big milestone, my friends. Congrats on earning it, and congrats on completing yet another rotation. I know that it's a long journey towards being able to practice with more freedom or complete freedom. I'm really glad you're getting more. All right, I'll pass the mic to our teaching points guru for today. Switching roles from presenting on Wednesday to actually doing teaching points today. Khashar, you want to say hi?
Hi, everyone. I'm Hashar, medical student from Iran, doing teaching points today for another RLR. Excited to be here.
Thrilled to have you, my friend. You've been I feel like you're the ever consistent figure on VMR this week, and I'm glad we're ending it with you on the teaching point. So we went to South Africa, we're going to Iran, and we're going to Brazil next for case number 8 from Vinny. Hi, Vinny.
So, hi guys, I'm Vinny. I'm medical student from Brazil. I'm very excited for today's case.
So Vinny, I'm really curious. Where is this? You don't tell us anymore, but where is this case from? What experience? Is this from? Yeah.
This case is the hospital that we do the internal medicine rotation. We have a couple hospitals here, and yeah, that's great.
Incredible, Vinny. It's amazing how many cases you're absorbing and presenting to us. It's really, really very cool, and very, very excited for case number 8. I guess we should pan the mic to Los Angeles to hear a little bit more from Prof. Rez before he starts discussing to explain his different background today.
I hope my entire focus to be on that one individual that made me, that humiliated me online on YouTube. I'm gonna discuss this case with you in mind, and I hope you appreciate the quality of this microphone.
Just for you. All right, Prof. Rez, you ready to rock and roll? Okay, all right, Vinny. The stage is yours, my friend.
All right. So Zachary, can I start? Okay. So for the first aliquot, we have a 38-year-old lady presenting with reduction in urine volume and right flank pain for 1 week. So the history begins about 2 months ago when she had an insect bite on the right gluteal region. And the clinical manifestations was an erythema and localized edema also. She believed to have taken cephalexin during that period, and thereafter she developed cramping sensation in upper limbs and bilateral paresthesia, especially in extremities, in the hands and feet, and right-sided facial deviation, and diplopia. She investigated during that period. The investigation composed a CSF and electromyoneurography, and she was treated with acyclovir for 6 days after positive IgG serology for HSV1 and 2, ending 15 days ago. So previously, She had a mild renal function alteration 1 month ago, but noticed reduced urine volume and onset of right flank pain just a week ago, with intensity 8 of 10, that is continuous, with no factors improving or worsening it, without associated fever or vomiting, but reports nausea without any precipitating factor. About his medications, she's not taking any kind of meds. And social history, she's a non-smoker, does not drink alcohol or use any drugs. Is born and raised in Brazil with no recent travel history. That's all.
Wow, Vinny, you say that's all, that's so much. Um, that's a very rich aliquot, and I think what we can do, Robbie, is maybe we can just go back and forth like very naturally. I will focus on the chief concern and then pass you the mic to layer in the preceding events to see, are they linked or are they two independent processes? Because remember, when you're solving a case like this, just taking a macroscopic point of view, either what preceded her current symptoms is related or it's totally unrelated. You have to explore the possibility that, in fact, it is related, but be open to the idea that it's totally unrelated. But whenever someone talks about decrease in urine volume, you've diagnosed acute kidney injury. You've diagnosed it. I don't need a creatinine to tell you this patient has acute kidney injury. By definition, acute kidney injury is a rise in the creatinine or a decrease in urine output. This patient has kidney injury. Now, when we approach AKI, you have all learned the schema of pre-renal, renal, and post-renal, right? But what's interesting about this is the flank pain. Like, how can we add the flank pain to make more progress to kidney injury? You see, I don't even have a creatinine and I'm going through with that DDX for AKI. In all comers, the low-hanging fruit, the easiest thing to reverse is a post-renal obstructive process or a pre-renal process. In men, this is often BPH, but both in men and women, this can be constipation, or it can be a medication that the patient is given, like iron, opiates, anticholinergic medication. So right away, I'm going to be interested in a bladder scan to see if there's any evidence of obstruction. But remember, when we do the bladder scan, we're looking for evidence of obstruction north of that bladder outlet. So that's the urethra or the bladder outlet. We don't know what's happening behind the bladder. So you can do a bladder ultrasound, it could be totally normal, and then you get a CT scan and all of a sudden you see there's 2 stones that are obstructing the ureters, for example. In most, we would like go ahead and put in a Foley catheter to really monitor urine output closely. And simultaneously, when you have lack of urine output, you need to quantify it. Is it oliguric, less than 500 cc's, or is it anuric? Because if it's anuric, all of you should be very nervous. And all of a sudden, you're going through the AEIOU's indications for dialysis, which includes acidosis, elevated potassium, intoxication, volume overload, and uremia. However, the pre-renal causes, oftentimes there's a good story, meaning you don't really need to do much for workup of AKI, but if the kidney injury is so severe that the urine output is diminished, then you better do a thorough workup. And the most common causes of pre-renal AKI include hypovolemia, and oftentimes patients says they've had diarrhea, they had nausea, vomiting, they had decreased PO intake. So that's a very hypothesis-driven review of systems. Other common etiologies include medications, like someone is put on an ACE inhibitor, on an ARB, or something that causes pre-renal kidney injury. But interestingly enough, when the urine output is so diminished, assuming that there was no evidence of a prolonged prerenal state that could lead to ATN, you have to be ready to activate the intrarenal AKI. I'm actually not going to dive any further into that intrarenal process because I would want a urinalysis. I would want chemistry tests before investing much cognitive energy in that. But the main takeaway I want you to leave with is decreased urine output is a form of acute kidney injury. And I'm going to pass the mic to Robbie to see like how he can relate it to the, because I think we have to go through that exercise even if they end up being unrelated.
Yeah, Professor, I think that's exactly what I'm thinking. I think there's sort of two things to try to see if they're related at all, which is the first in terms of the sequence of events is to say, is the insect bite at all related to what happened? And I think that, you know, most insect bite do not result in a neurological syndrome. So even that query is that related at all is very, very interesting. And I think I'm not really sure what the neurological event localizes to, but what I am sure is that unfortunately, the use of HSV1 or 2 antibodies to diagnose this syndrome is restricted by the fact that all that they do is establish that the patient has latent HSV1 and 2. It's no different than trying to diagnose active tuberculosis with a quantiferon gold. All that we know is that this patient could have HSV1 and HSV2, but we did not prove that she has HSV1 and HSV2. So part of me is wondering to try to understand what this clinical syndrome is and what's the neurological dimensions and what's the gaps in my data analysis are, is the facial weakness or deviation upper motor neuron or lower motor neuron? Is a diplopia a cranial mononeuropathy like cranial nerve 3, 4, 6? Or is it actually an ocular muscle issue or an ocular nerve issue or a neuromuscular junction issue? So I think the most telling thing would be what you have available to you right now, which is to watch and understand what the evolution of those symptoms over time. Because you probably don't have access to the data about what happened 2 months ago with high quality, but what you do have access to in the moment is, does she still have diplopia? Does she still have facial palsy? And then you would be able to say, this is a either spontaneously resolving neurological syndrome, or this is a neurological syndrome responsive to acyclovir. And so maybe before we speculate further, unless Vinny, do you have, unless you're planning to reveal that information, do you know, did her syndrome resolve, or is she seeing you and with this ongoing persistent neurological syndrome?
Yeah, so at the first moment, she was presenting the neurologic symptoms also. And then during the hospital cares, like that fluctuated.
I see. So when she was reporting this history of right flank pain and decreased urine output, at the same time, she still had diplopia and had a facial deviation. Is that right?
Yeah, that's right.
Interesting. Very,
That's right.
very interesting. So it seems like this neurological syndrome is ongoing. And so I think that I would probably just leave it at that in terms of trying to further characterize a neurological syndrome, because I think what you really need to know is a neuro exam to try to figure out and localize this process. So I guess the question then before us is it related at all to her kidney dysfunction? And I think in general, when you're trying to connect two things, they can be connected in 3 different ways. Either the initial abnormality, let's just call it A, is directly causing B. So if you're trying to connect a positive blood culture and a fever, you would easily say the positive blood culture is causing the fever directly. The 2 other ways are all vertically oriented. Either something is underneath A or B. So if you're visualizing A and B, instead of something directly connecting them, underneath both of them is something C. So what connects PJP and toxoplasmosis? Something underneath called HIV. The other way to connect things as part of this trifecta of direct connection underlying is underlying is something overlying. And A and B are connected not because there's something hidden underneath or that A caused B, but rather something was done as part of the treatment of A. It was sprinkled on top by us. So the question here is the neurological dimension directly implicating and causing kidney dysfunction? Very unusual. Is there something hidden underneath? Very important to assess for, especially when the syndrome is not coalescing very well. Is there some intervention that we did that connects the two? Absolutely, there is. But I think it's too soon to speculate on what that, on more details on that. So yeah, I'm perplexed, Prof. Rez. I'm really curious. In the moment, I'd be really, really concerned about the neuro dimension and would love to assess that further and then see what progress we can make. All right, Vinny, the mic is yours, my friend.
Yeah, just to clarify, the patient will treated the acyclovir treatment 15 days ago, and about the question that was asked in the chat, she did not had a renal alteration, but she did a mild renal alteration function a month ago. That's it. Now proceeding with the and despite the treatment with acyclovir has ended 15 days ago, she persists with some neurological symptoms. Okay, so that's important. And for the second aliquot, I'll bring some previous hospitalization findings, and they did a CSF analysis that came with 80 cell count with 96% of lymphocytes, 4% of monocytes, protein of 26, glucose of 49, negative bacterioscopy, negative fungal study, negative India Inc., syphilis, VTRL non-reactive, and negative oligoclonal bands. They did also an MRI of the brain that showed extra-axial cystic formation consisted with an arachnoid cyst in the left anterior temporal region. They did an MRI of the cervical spine that showed just compressive myelopathy at C4, C5, and C6. And electromyography that finds consistent with lower motor neuron impairment. The serum electrophoresis that is normal. And now I'll bring some current hospitalization findings. So for the initial examination, the patient appears in regular general condition with a respiratory rate of 16, a saturation of 95 on room air, and heart rate of 84, and blood pressure of 150/70, a capillary refill of less than 3 seconds, abdomen normal, and extremities normal. And the neurological exam, the patient was alert and oriented with right hemifacial paralysis and altered eye abduction. There was no visual field changes. Motor strength in the lower limbs was grade 4 bilaterally. Neurological symptoms varied, as I said, during hospitalizations, with sensory to motor deficits manifesting in different body parts. And some days she experienced lower limb paralysis, while on other days she had like tingling in the right hand. So yeah, I'm just in the middle of the aliquot, but I think that I'll stop here. Okay.
Oh man, this is a very, very intriguing case, and I think that it goes to show you that you have quite a bit of a problem at hand. And gosh, I'm trying to figure out, maybe Prof, we can just go back and forth. It's hard to figure out how to divide this data, but I think immediately you're struck with with trying to interpret the neurological exam, and you can see how much progress you make with localizing the diplopia and localizing the facial paralysis. The diplopia can be due to so many things, but Vinny told us that the reason she's having double vision is she is having a right abducens palsy. And so she has a cranial nerve 6 mononeuropathy. She does not have a neuromuscular junction issue. She doesn't have muscle issue. It's just that her cranial nerve 6 is not moving right. At the same time, we also learn that her whole face is paralyzed, which tells us that she has a right-sided lower motor neuron facial palsy. And we learn, which we'll analyze later, that she also has oscillating neurological weakness and sensory changes. Very interesting. But here's the tension point. I think Fridays are all about the paradoxes. You have a right facial palsy that's in lower motor neuron distribution, yet you have inflammation as evidenced by the LP in the CSF. How can you have a lower motor neuron lesion yet have inflammation in the CSF? And the answer is actually a beautiful one. It's one which localizes the diseases to the exiting spinal nerves and brainstem nerves as they exit. This combination of lower motor neuron disease, lower motor neuron dysfunction, but disease in the brain localizes the lesion to the subarachnoid space. And the subarachnoid space is one of the hardest diseases to try to localize because it bathes all the nerves and nerve roots exiting the spinal canal. And may be a simple and elegant explanation for why this patient has this nerve pinched off and this nerve pinched off and this nerve pinched off and this nerve pinched off. So I think the progress that you can make by seeing a peripheral nervous system dysfunction coupled with central nervous system inflammation is to wonder, is this patient having a subarachnoid disease? The other localization could be that she has radicular disease or disease of the nerve roots as they exit, or anterior horn disease. But this is certainly seems to be a disease at the interface and intersection between the CNS and the PNS. Not at the anterior horn because she has sensory symptoms, not isolated radiculopathy because she has motor symptoms. So either she has a really advanced, severe, multifocal radiculopathy, or she has disease in the subarachnoid space. So maybe I'll stop there. I'm curious how that reflects with you, Prof. Rez, and what thoughts you had about what this disease might be and things crossing your mind.
Robbie, that was just phenomenal localization. I was trying to reconcile the peripheral nerve and the central nervous system findings, and you taking us directly to how that localization can happen was really, really interesting. I think for me, something that's a little bit complicating this case is this compressive myelopathy between C4 and C6. She's a young person. We weren't told of any activities that may have caused degenerative joint disease, but it seems like she's quite young for that. And that also confounds stuff in terms of some of her motor and sensory findings, like how much of it is due to what's happening in the C-spine and how much of it is due to the CNS inflammatory process. Because remember, if you're having a mechanical compression, you shouldn't get this sort of inflammatory milieu within the CSF. And furthermore, the fact that you have these cranial nerves involved, we know we're north of the cervical spine. We're brainstem and above. So I think that we just got to be cautious. Like that's the only thing that has gone in my mind on like not dismissing the findings to the compressive myelopathy. And truthfully, what I would be doing here is just like activating our schema for lymphocytic pleocytosis and just going through the various causes. And just very briefly, that schema includes malignancies like lymphoma. And because lymphoma can cause a lymphocytic pleocytosis. And the interesting thing about lymphoma, it can infiltrate cranial nerves. It can infiltrate at the level of the brainstem. Because remember, the reason Ravi said it was a lower facial motor neuron process because the whole face is paralyzed, right? If it was just a cortical process, only half the face, the bottom half would be paralyzed because you get bilateral input to each side. But if you're blocking the nerve to both sides, you're gonna have complete paralysis. So now I'm going through that scheme of lymphocytic pleocytosis, and I'm asking myself, what might cause, for example, a basilar meningitis? Lymphoma is an interesting thought, so I'd be curious if they sent flow cytometry on that CSF sample. But because she's a young woman, you have to, I mean, not just because she's a young woman in all comers, you have to think about autoimmune etiologies. And those include stuff like lupus, sarcoid, Sjogren's. Of these three, we know that sarcoid can also cause granulomatous infiltration of various nerves and lead to such a phenomenon. And then you got to think about demyelinating conditions, most notably MS, ADEM, NMO. These are central nervous system processes, so they shouldn't be the peripheral nervous system. And then finally, you have your infectious bucket. And in that infectious bucket, you know, it's the viral stuff, probably most commonly like HSV, like enteroviruses, like HIV. But then you can have atypical infections. And you might be saying, well, where's the science of infection if this is an infection? Remember, once you're in that subarachnoid space, you're behind the blood-brain barrier. And that's the way that the brain protects itself from the foreign environment. And because there's that blood-brain barrier, it may also prevent it from being immune activated. So, Robbie, I think what I would be most interested in is whether that MRI was done with gadolinium. I might even do specific MRI, just looking at the nerves to see if there's any enhancement to suggest an infiltrative process. And I would be sending, you know, flow cytometry, workup for atypical infections, and knowing those infections like TB, the granulomatous processes, sometimes the CSF is not the best test and it takes a while to get to the bottom. This is the type of case where I would probably repeat an MRI and keep going until I get to an answer. But I'm most concerned for a widespread infiltrative process that is causing a lymphocytic pleocytosis. I'd love to hear from you, man. Like, I don't know if I'm putting too much weight on this, but I feel like that's a finding that must be explained. Like, we have CNS inflammation, we have lymphocytes, whatever's causing her presentation has to be able to explain that.
Yeah, no, I'm right there in the same place with you, Prof. Rez. I think that the other dimension we were given about the kidney stuff is interesting to anchor in, and also just a reminder to make sure that we try to figure out what the systemic fingerprint of this disease is, because it's so easy just to get distracted on the neurological dimension. And so, yeah, I think that I'm right there with you. I think this is a process that is likely affecting those nerves. And the question is, what is it? And I think that it's very unlikely to be a pyogenic bacterial infection based on the time course and based on the lymphocytosis. So a whole range of viral, spirochete, and even parasitic infections are at play. And only after you exonerate those do you really have to start to worry about non-infectious stuff, but including malignant infiltration. But I guess the thing to probably get in the moment in real time, as you said much long ago, is to make sure that this patient's not having reduced urine output and flank pain because of urinary retention from the fact that her nerves aren't working, and that would really change the calculus. All right, Vinny, mic to you, my friend.
All right, so for the first setting of labs, we have a CBC that is normal, chemistry that is normal, albumin normal, bilirubin, liver function test normal, LDH normal, iron of 59, which is decreased, ferritin is normal, renal function, we don't have in BUN, but we have a urea that is high of 246, and creatinine that is 14 with a baseline of 1.5, a glomerular filtration rate of 3, sodium of 136, potassium of 5, phosphorus of 7.4, CRP of 7.4, lactate of 0.4 and bicarb of 20. Urinalysis is normal in serologies, syphilis, HIV, hepatitis, panel, and DSH and T4 all came back negative. And we have also cultures, urine and blood cultures are negative. So the initial management, she was started on doxycycline for suspected Lyme disease. Despite being from Brazil, where Lyme is not endemic, Lyme serology was negative. Afterwards, HSV 1 and 2 IgG was positive at this point. Renal and urinary tract ultrasound showed slight dilation of the collecting system. And so just to summarize a medical impression, to this point, we have a patient with migratory multiple mononeuropathy with renal dysfunction, likely triggered by an suspected insect bite 2 months ago. Notably, she developed vaginal bleeding during hospitalization, which improved with tranexamic acid. She was prescribed packed red blood cells, but experienced transfusion-associated circulatory overload. A urinal biopsy then was performed also, which led to a pure renal collection and worsening clinical status. Then she was admitted to the ICU for the first time. She was intubated due to hypoxia, and at this point, our medical team had no idea what could be occurring due to the clinical manifestations that a first class doesn't connect. So that's all. And for the next aliquot, I'll review the ICU history. And yeah, that's it.
That's very helpful, Vinny. What a case. I think I'll just share my quick thoughts and then pass the mic to Robbie to add to them. I think that, the creatinine being so elevated is quite concerning. And you don't need to go to medical school to make a statement like that. Interestingly, the kidney is usually a bystander of whatever systemic process is happening, meaning I have pneumonia and I may have kidney injury. I have heart failure, I may have some kidney injury. It's so sensitive to volume status changes that it rarely takes the center of stage when you're solving a clinical problem. But if the creatinine is 14, this is different. You really gotta pay attention to it and assume that whatever is causing pathology elsewhere, it's also causing pathology at the kidney, meaning it's one of the primary sites. And so how do we reconcile that with a completely normal urinalysis? Because I bet what all of you were looking for on that urinalysis was, is there protein, albumin specifically, to suggest that we're dealing with the glomerulus process? Is there red cells and white cells to say that we're dealing with an interstitial process? Is there a little bit of protein to tell us that we might be dealing with a tubular process? The truth is that one data point doesn't dissuade me because it's just one data point. I would want to repeat the urinalysis. I would send a spot protein to creatinine ratio, assuming that there's urine that's being made, to make sure I'm not dealing with non-albumin proteinuria that can happen when you have tubular injury. Yeah, so I just repeat the UA like I would a troponin. And with that creatinine being that high, it's just, there was a time actually when I was at Hopkins and I had a patient who had oral thrush and came in with a creatinine of 14. And we gave that person fluid and the creatinine dropped to 1.5 in like 2 days. So it's not to say that you can't have the kidney be so injured from a process happening elsewhere because of the effect on the cardiovascular system, and then the subsequent effect causing ATN. Actually, the interesting thing here would be a specific gravity. Like if you see that 10-10 sign of isostenuria, it might tell you that those tubules are not functioning right. It may further substantiate that hypothesis. But something else that's happening here, it seems like the lungs are down now. So now we have like multiple organ failure. The kidney is down, the lungs are down, seems like the nerves are down, And the question is, how can we connect all these together? If you guys go back and listen to last week's RLR or the week before, when Kara presented a phenomenal case of DKA leading to such severe hypovolemia, it caused severe acute liver injury, the kidneys were shut down, etc. So hypotension is a way to link like solid organs like kidney, liver, but the lung, I wonder if she's volume overloaded because she's not making much urine, and that if your creatinine is 14, you don't have functioning nephrons, and it's going to be really hard to diurese such a patient. So then they're intubated because of that. So what I'm trying to do here right now is like I'm really trying to figure out which organs is housing the primary site of pathology and which organs are just a consequence of what's happening to the body. The kidneys got knocked out. Now she can't excrete urine. Fluid built up in the lung. She gets intubated. Or do you have a multi-systemic process that's hitting the nerves, hitting the kidney, and hitting the lung? The question of where to go from here is you're going to definitely want to pro BNP, an echocardiogram, cross-sectional imaging of the chest, and we'll follow up the renal biopsy. And I would have a very low threshold to repeat the MRI with gadolinium to look for any kind of enhancement that may suggest a breach in the blood-brain barrier that would say it's an inflammatory process. But Robbie, I'm still not, I don't really have a firm grasp on the problem beyond the neurologic dimension. That I think is real, but the rest, I just don't know what's a consequence. Like, it's like a domino effect. Like that led to whatever, transverse myelitis, no urine output, kidney injury, which led to volume overload, lung failure, intubation, but everything is coming back to the nerves.
Reza, I hope your golf game is as good as your discussion game today. Oh my gosh.
Well, can I tell you, it will not be, because my golf game is trash. It's so, just a quick story, Robbie, if I may, just very brief. I went with the chief of staff at the GA, like the boss of the boss. Dude, it took me like 6 shots to get to his ball after 1 shot. And I promise you, he's never going to invite me again. I basically lost that golf buddy.
Well, you know, it'll catch up, Prof. Rez, it'll catch up. I think that the struggle that I'm having too is also trying to identify the problem and knowing that the neurological dimension is the most clear aspect of it. And it's so interesting how proximal it is that the neurological dysfunction develops in a manner that is far preceding the eventual dysfunction. Because if I remember correctly, her neurological dimension was 2 weeks prior to her falling off this cliff, and so really analyzing the sequence of events is so fascinating. And I think I'm wondering now, is her profound renal failure, again, a distractor in that is merely a consequence of either hypovolemia and ATN, or is it the effect of acyclovir and crystalline deposition of acyclovir, which would be very unusual if she hadn't received IV acyclovir. So that would be an open question to ask. But yeah, I'm wondering what the localization of her kidney dysfunction is, because if the UA is negative and it's this severe, well, I should say, if it's this severe, it's probably not pre-renal alone. And if the UA is negative, it's probably not the glomerulus. So we're left with tubular interstitial disease, the most common of which is ATN, or we're left with vascular diseases, like a microangiopathic process. And the reason I'm thinking vascular disease is somewhat of a possibility is because of the vascular fingerprint she's otherwise having, especially her bleeding. She's bled significantly after a kidney biopsy, which is not unheard of, but she's also having spontaneous vaginal bleeding requiring transfusion. And presumably, if she's having vaginal bleeding with normal coags and a normal platelet count, then it's likely that she has a structural cause potentially in her blood vessels that is causing her to bleed. So I think the neurological dimension is very, very intriguing, but I too am struggling to make a tremendous amount of progress, except to start to wonder if the unifying feature here is a disorder of blood vessels, given the fact that they're bleeding, and maybe they choked off the kidney, and then maybe they're choking off the nerves that this patient is clearly experiencing. So Yeah, I think it's very, very hard to wrap this disease around, and I think we probably need a breakthrough in the data to help us gain momentum. And potentially that breakthrough is that kidney biopsy, which will tell us the mechanism of kidney dysfunction, which may help us back calculate what else might be happening to the other organs. But I'm nowhere near being confident about diagnoses because I'm nowhere near being confident about what the nature of this problem is yet. All right, Vinny, tell us more. You have us very, very intrigued.
All right, so about the initial ICU course, she was intubated on the first day due to decreased consciousness and hypoxemia. It was repeated a CVC. Now the hemoglobin is 5.2, hematocrit of 15, platelets of 167, leukocytes of 18 with 80% segmented. The renal function, the urea is normal. Now the creatinine decreased to 5.2, sodium 129, potassium 4.6, which is normal. And they proceeded with some autoimmune markers. The ANA was positive, anti-DNA was negative, and Smith negative, and Smith positive, C3, C4, and C850 within normal range. And now we have also a CT of the pelvis with contrast after the vaginal bleeding, which reveals posterior retroperitoneal hematoma near the left kidney, cervical mass suspicious for neoplasia, bilateral ureteropelvic dilation, and irregular thickening of the middle rectum, suspicion also for neoplasia. So afterwards in the ICU, post-therapy was initiated in an attempt to improve clinical condition. And after a discussion with the neurology team, it was maintained in hemodialysis. She received 2 more units of packed red blood cells, and she was extubated 2 days later. So during ICU stay, she remained drowsy and minimally responsive, had a urinary tract infection due to proteals, and was treated with meropenem. And after 17, so she was extubated 2 days later, and after 17 days in the ICU, we waited for conditions to perform uterine cervix biopsy due to the suspicion of malignancy based on the CT revealing these masses, and awaited for some antibody results. So basically that we're trying to improve the clinical condition to the patient to perform other tests and biopsy, and it was difficult to do that, and we need to wait weeks so we can continue the investigation.
Vinny, I'm speechless. I don't even know I can't even imagine how hard it was to be able to try to help this patient and make progress because of all the surprises that keep coming your way. I'm curious, do you know how many aliquots you have left, just to be mindful of time?
Yeah, I have just more 2 aliquots, one at a short.
Okay. Yeah, I think, Professor, I'll just kind of reflect on what we found. I think leukocytosis that's this high in a hospitalized patient is not uncommon. And I think the receipt of broad spectrum antibiotics like meropenem is also not uncommon. It's really interesting to see that she has an isolated anemia and that she's bleeding so much. And I think we found 2 structural lesions as to why. The first is that she got a poke in her kidney, and the second is that she has a structural lesion in her gynecological tract, which is in her cervix. And so I suspect that the hypothesis for a vascular problem diminishes when you have a structural issue, an explanation for both lesions. And unfortunately, in young women who have not received their HPV vaccination, the possibility of invasive squamous cell carcinoma of the cervix which may be infiltrating and compressing the rectum, and also unfortunately infiltrating and compressing the kidney is very, very plausible here. And an obstructive uropathy is very much recognized to cause this picture and of the kidney dysfunction. So I think now the neurological dimension it remains a mystery. I think the bleeding dimension and the kidney dimension may be explained by the presence of a pelvic lesion, not the prostate, which is most common in older men, but potentially here the cervix, an invasive cervical process. Now, how that relates to the neurological dimension, I'm not yet sure. We can speculate in general, but I think that would be the open question. I think the kidney probably bleeds into the pelvis, and the neuro dimension is still, I think, very, very hard for me to wrap in. Or what are your thoughts?
Yeah, I really have zero to add. What it seems is like, if you think about it, our immune system is there to protect us against infection and cancer. I think we can speculate that this patient's immune system is altered. It's altered. You have this malignancy, it's infiltrating. We've explained the urinary retention, we explained the bleeding. And I wonder, in this context of altered immune system, if she's more vulnerable to something like HSV or a viral infection that may be a good explanation of the neurologic, meaning can both phenomenon be occurring, simultaneously because of an altered immune system? I don't know enough about cervical cancer, Robbie, to know like what's the risk of perineoplastic syndrome, what's the risk of it infiltrating nerves. Like I just don't know enough, and I don't think of it in that way. But I know with breast cancer, we've seen it invade everything, the marrow. So it could all be the cancer that's going everywhere, or it could be that we have the cancer, we explain some of the problems, but because of the altered immune system, she also is at risk of these viral infections that are affecting her nerves. That's the best. What are your thoughts on that?
Love that. I think that's such an elegant way to combine things for sure. I love it. All right, Vinny, I know you have two more left. What do you have next?
Yeah, okay. So now she came back to the ward, and due to the suspicious rectal thickening, it was performed a rectal sigmoidoscopy, and I need to tell that it was the same thing. We was trying to do the ball preparations during the weeks. We tried 3 times, and she wasn't able to handle it, and we hold the exam, and then when she was clinically able to do, we then performed a rectal sigmoidoscopy, and the initial impression was an infiltrative, hardened, and fixed lesion in the middle rectum. And while awaiting biopsy results, the patient developed another a bloodstream infection by Enterococcus faecalis, and worsened clinically, necessitating antibiotic escalation to amikacin. So yeah, the next aliquot will review the diagnosis.
Wonderful. Thank you, Vinny. I think someone who is hospitalized, is undergoing procedures, probably has a weakened immune system, is at risk for all these types of bacteremias. But them themselves, it's very difficult to explain the other findings that this patient has. So I think at this point, it just becomes, what does the pathology show? And that's probably your answer. I don't know, Robbie, do you have anything more sophisticated to add there?
No, I think these cases are very, very tricky when you don't have the disease coalescing into a mass. And I think this case would be so much harder to make progress on if you had to rely on the lab to make the diagnosis. And I think that the disease is really living there in that space, in that pelvic region. And so I think the pathologist is very likely to be able to help you. I'm just sitting here wondering how to connect these things before the answer is revealed, only to stretch my reasoning. And gosh, I have such a hard time because, Prof. Rez, we've seen quite a few cases of patients with colon cancers who have leakage, and then they get bacteremic But you know, for it to make it to the CSF seems so unusual, although I think we've seen a few cases of that with strongy. I also know that schistosomiasis can cause a prominent neurological dimension, but I have a hard time believing that this is schistosomiasis in the bowel. So yeah, I don't know. I honestly would be very, very curious what this pathology is, and I think it's probably going to be a solid tumor. There's this really cool entity that Ravi taught me about, which is when patients have a lymphoproliferative disease or a lymphoma, and they get a mosquito bite, and they just get very, very like, yeah, it's called hypersensitivity to mosquito bites. Long story short, there are times when you get a biopsy and you have a really reasonable suspicion what it's going to show. But there are other times when you're like completely, utterly open to anything the pathologist says. And this is one of those times where I think I don't have the fingerprint of the presentation short of the pathology doesn't really help me predict what the pathology is at all, not even close.
So, okay, about the final aliquot, the patient developed a hemodynamic instability and required intubation due to shock afterwards. She had pulseless electroactivity that was revived. Her immunosuppressive state led to another UTI, but now with Pseudomonas treated with polymyxin B and meropenem, and she remained on saline and amikacin. And due to her critical condition, she was again transferred to the ICU, where she developed a septic shock and a new bloodstream infection, now by Acinetobacter. And after 95 days of hospitalization, and the second day of her second ICU stay, she was noted to have isocaric mediatric pupils, non-reactive to light, no cough reflex, and coma. So brain death was confirmed following the development of hypoxic ischemic encephalopathy, with a control cranial CT showing loss of corticals and subcortical differentiation. And about the mosquito bite, it intrigued us because actually there is no relation. Mainly with was a clinical like peripheral neuropathy that manifested at a certain point of her lifetime, and she associated with the mosquito bite. So that's the tricky of medicine. Yeah. And the pathology reveals the rectal malignancy. So the biopsy was performed like in the final days, and she already was in deterioration. So the diagnosis, the final diagnosis, I think that we can put like some paraneoplastic chronic, and it is hard to define if it is a sensory motor neuropathy or sensory neuronopathy secondary to an infiltrative, undifferentiated, non-small cell malignancy of the rectum. And yeah, that's all. I'll leave for some comments.
Oh wow, Vinny. I mean, this is just I've never seen anything like this before. I really must confess that. But to be honest, I remember Prof Rez had suspected infiltration very, very early on. It's obviously a tragic outcome for the patient, but I'm curious, Prof Rez, how do you reconcile this finding?
Yeah, I think I just want to quickly say, Khashayar put in the chat how sad it is for someone to be hospitalized 95 days. So really, really tragic outcome. But I think it just goes back to like how you were helping frame the case, Robbie, where you told us don't lose sight of the kidney. And that CT scan, I think, was most helpful to say like there's an infiltrated process. I'll be honest, I still can't explain the neurologic dimension. Well, I really can't, unless you had leptomeningeal enhancement and then you had leptomeningeal carcinomatosis. You remember that case we had on RLR of the leptom from the solid lung cancer. It's usually long breaths, but I'm sure rectal can do it. So I would have to just review that MRI with the neuroradiologist. But if you did have GAD enhancement in those sections, then that would be a very good explanation that is metastatic cancer to the leptomeninges causing these neurologic manifestations. But that patient too had like cauda equina, had brain stem. You remember that guy? He was just couldn't urinate. It was so much. What do you think about that hypothesis? Like a leptomeningeal
I think it
pathology?
makes so much sense. He really, really does. Yeah. I think you clearly know that this is originates in the rectum, maybe infiltrated anatomically into the cervix, and then probably infiltrated into the nerves. I think that is a tragic, tragic thing. And to think a 38-year-old woman is getting such invasive, aggressive rectal carcinoma is very, very sad, devastating, and very, very intriguing for sure. Vinny, what did you learn? How are you putting this together from your reading or from the experience?
Yeah, so couple points that I learned is that when anything like doesn't make any sense, we don't have like any sense or suspicions on how to proceed. We need to think about malignancy and perineoplastic syndromes, and about the chronic sensory motor neuropathy. Like the patient like presented at first glance with a syndrome like that resembles mononeuritis multiplex and some also sensory symptoms, and we can have truly like both involvement of sensory and motor nerves, but it will differ from sensory neuropathy, and that is more related to perineoplastic syndromes. And we should have like send a perineoplastic panel as Anne Marie asked it, and yeah, we don't have any clue about that, about this point, and anti-WHO antibodies maybe should reveal it. And yeah, I think that's it. And yeah, I don't have like too much to talk actually, basically that.
I guess maybe to summarize, Prof. Rez was asking very early on neuro and kidney, how are they related? And I think we're coming to the conclusion that there was something underlying them, namely rectal cancer that was causing obstructive uropathy and either perineoplastic or infiltrative disease, which is really, yeah, wow, I have a lot to learn from this case. Thank you so much, Vinny. Pasha, I'll pass the mic to you for your very well bulleted and highlighted teaching points. I'm eager to hear them.
Thank you so much, everyone, both for a great discussion, and thank you, Vin, for the great case. This was both a very tough case and a very upsetting case. So let's do her justice by learning more and more from her. The most important thing that I learned during this case was that we have a case with lots of data points from the beginning, where we have multi-system involvement, till the very end. We have many data points, and finding which ones are relevant to us, to our framing, is the most important task here. So we did just that as we went on with the case. Our first point of focus was the AKI. We have a decrease in urine output, which just points, which is enough for an AKI diagnosis. Now we have to go for pre-renal versus renal versus post-renal. We know that the post-renal cause is our easiest one to reverse, so we have to focus from that. We learned that the most common causes in men is the BPH, and the causes in women are different factors, but mostly related to drugs and constipation. We can gain more info into the severity of our situation with monitoring the urine output. Oliguria versus anuria are different in their severity. Now, going forward with the case and recognizing more and more of the neurological dysfunction that we were seeing in the patient, we have to understand causation versus longitudinal connection. By causation, we mean two events that cause each other, either neurodysfunction leading to kidney dysfunction or vice versa, versus an underlying cause in between the both of them that is causing the both. And many things can help us in that. First and foremost, the sequence of events and how the symptoms respond to both medication and how the symptoms develop. Here we finally arrived at a presumed, at a hypothesis that the invasive rectal carcinoma was the underlying connection here, causing an obstructive uropathy and a possibility of a leptomeningeal process caused by this neoplastic syndrome. But there were many pathways that we explored, one of which was that the presence of this infiltrative process alone is pointing to a possibility of an altered immune status, which can explain the vulnerability to HSV and connect us to neuro that way. At the same time, we have a susceptibility to bacteremia, which can explain many of the multisystemic things that we were seeing. One thing in understanding the neurological deficit was our approach to localizing the neurosymptoms. What I enjoyed personally here was our framing of we have an anatomic dysfunction, which at the same time with a systemic inflammation. Where can we connect those? At the point where they exit each other, like we have a process that is localized by the anatomy, joining the systemic causes, which pointed us to an subarachnoid space possibility of subarachnoid space dysfunction disease there, with the hypothesis of how this inflammation can be explained, either as an infiltrative process, which seems more likely now when we look at it retrospectively, a demyelinating process, or an infectious process. Again, we don't have an exact answer for this, but retrospectively, infiltrative metastasis is the more likely cause. As the case was developing, one other thing that caught our eye was the extreme elevation of creatinine. I was monitoring the chat, and everyone was surprised by how elevated the creatinine was, and at the same time, the UA came back normal. So what we learned from this was that first of all, when you see this, doubt the UA, repeat it, and say if it repeats itself. If it repeated itself, understand the role the kidney plays in these systemic events. It usually is a bystander, but such an elevation in the creatinine is pointing to that the pathology is happening at the site of kidney. And that pathology is either primarily located at the kidney, again, causation, the kidney is the causative event here, or there's another cause somewhere else that is causing pathology directly at the kidney, because kidney is usually a bystander because of its sensitivity to volume status. Finally, we arrived at the tissue is the issue, and the final retrospective presumed diagnosis that we arrived at was solved by the tissue. Usually when we send a pathology request, we have an idea of what we're expecting for it to come back. But this was one of those rare instances where we were waiting for the pathology to guide us. And I hope I was able to capture most of the learning in such a complex case. Thank you so much, Winnie, for bringing it to us. And thank you for the great discussion.
Kashayar, you didn't just capture most of the teaching points. You did something I've never seen done on VMR before. You took a concept that Rabih shared, because Rabih loves to be poetic when he speaks, A, B, C, underlying, overlying together, and you actually applied it to this case, and you connected the dots in real time. I think that's so special. You know, I wrote in the chat, it makes me want to adopt you, but I know that's not possible. But you did a really good job. I'm curious to hear Rabih's reflections too on your teaching.
Oh, Prof. Rez, I think the email for this session said VMR with Reza and Ravi, but I think what it really should have said was VMR with Vinny and Khashaya. It was a really, really special session. Both of you guys. I mean, you're early in your training in very, very far parts in the world, and yet together in synergy, you brought us an absolutely fantastic case. But let's not forget that there's one other hidden gem here, which is Zakaria, who both had described such a complex case and feel the heat of coming up with a good problem representation. So to all three of you, a massive, massive kudos. Really, really appreciate you all. And thank you for keeping the heartbeat of VMR very alive today and are certainly the future of it, all three of you. Thank you.
Now everyone wish me luck at hitting the ball in golf. Take
Good luck,
care.
Prof. Rez. Bye. Bye, guys.